radiologic left the repeat X-ray with binder done 4 hours after. So we can see here, we can see complete fractures of the right iliac crest, superior pubic ramus, and inferior pubic ramus. And then it's better visualized 4 hours later with the binder. So for the malgaignant fracture, it is an unstable pelvic fracture involving one hemipelvis. Most cases are due to vertical shearing forces, and the patients tend to present following trauma with pelvic or hip pain. It is also associated with the highest risk of hypovolemic shock, and mortality rate can increase up to 25%. So it consists of two ipsilateral pelvic ring fractures, one fracture involving the superior and inferior pubic rami, going through the obturator foramen, and then another fracture involving the iliac crest. So some potential associated injuries would be pelvic hemorrhage, bladder rupture, and urethral rupture. And then the major pelvic ligaments can be disrupted, and this would have greater association with vascular injuries due to the close proximity of the pelvic vessels to the major ligaments and the pelvic bones. So for management, initial management is done by application of the binder, which was done in our institution. And then operative treatment is by posterior stabilization with plates or sacroiliac joint screws as needed. And then definitive management would be through open reduction and external fixation or percutaneous spinning. Thank you.
Okay, thank you, Nico. So
And
any
then I'm going
questions?
to
Any questions? Ay, sige, tanong muna natin baka merong questions, no? So, yung mga nabanggit ni Nico na associated complications and findings in bladder, in pelvic fractures, no? So, take note of those things. So, that's why in some, that's one of, a common indication for doing a fast ultrasound, no? If you're thinking of, if you see pelvic fractures in, in, um, in X-ray, in a trauma patient, he would oftentimes request for fast ultrasound. Also, yung fast ultrasound is an ultrasound that it's a abdominal ultrasound that you do to check for signs of bleeding, intraperitoneal bleeding. Um, so especially if the patient would present with hematuria, so automatic pinapa-fasting. There are common associated findings. So madalas din kasi makita yung mga ganyan fracture sa sa parang straddle injuries in patients who are in a motor vehicle accident wherein they're riding a motorcycle. Okay, so walang questions. Sige, Nico, you can proceed with the next topic.
So next, I will be presenting the X-ray of the paranasal sinuses and mastoids. So for this presentation, I'm first going to wait. So for this presentation, I'm first going to discuss the basic anatomy of the paranasal sinuses and mastoids, the views needed to evaluate these, and the common pathologies seen on X-ray. So the paranasal sinuses are air-filled spaces within the facial bones, lined by pseudostratified columnar ciliated epithelium, and they contain both mucinous goblet cells and serous glands. The mucosa of the paranasal sinuses are attached directly to the bone and is referred to as mucoperiosteum. So the functions for the paranasal sinuses would be to humidify and warm inspired air, add resonance to the voice, and absorb shock to the face and head, mostly for blunt trauma. They also increase the olfactory membrane area and provide thermal insulation for the brain. So the frontal sinuses are found midline in the anterior frontal bone. They are divided midline by an intersinus septum, and inferomedially, the frontal sinus narrows towards the frontal infundibulum, and then the frontal ostium, which drains to the frontal recess. For the ethmoid sinuses, they are the first sinuses to fully develop, and they begin to form in the third to fifth fetal month. They are present and aerated at birth, and here in the picture, we can see that they are colored yellow. So they are 3 to 18 cells. There are 3 to 18 cells in each ethmoid complex, and they are divided into anterior and posterior groups by the basal lamella. The anterior air cells drain into the anterior recess of the hiatus semilunaris and middle meatus via the ethmoid bulla. The posterior air cells drain into the superior meatus and the sphenoethmoidal recess. For the maxillary sinuses, they are the ones highlighted in green. Um, they are found within the body of the maxilla, and they are lateral to the nasal cavities and inferior to the orbits. The maxillary ostia are found in the superior aspect of the sinuses, and each sinus drains via its maxillary ostium into the ethmoidal infundibulum, then via the hiatus semilunaris into the middle meatus. So for the sphenoid sinuses, they are more posterior relative to the other paranasal sinuses. So they are more easily visualized on the lateral X-ray, and they are asymmetric air cells in the body of the sphenoid bone. They communicate with the roof of the nasal cavity via the sphenoethmoidal recesses in their anterior walls, and they drain via their ostia into the sphenoethmoidal recess. For the mastoids, they are part of the temporal bone and represent the posterior wall of the middle ear. They also contain mastoid air cells, which can be seen here as pneumatization. So the pneumatization extends throughout the air cells, beginning from the mastoid antrum. And these mastoid air cells communicate with the tympanic cavity of the middle ear via the mastoid antrum. So for the views, first we have the basic frontal view, and it is used mainly to evaluate the facial bones in the settings of trauma, but it can allow for quick evaluation of any obvious paranasal sinus or mastoid pathology. But the main drawback here would be the overlap of facial bone structures makes it harder to evaluate the sinuses than with angled views such as Caldwell's or Waters. So for the Caldwell view, it is meant to show the frontal sinus more clearly than a standard frontal skull radiograph. So it is obtained with a PA beam with 15 degrees of caudal angulation. And then the indications for this view would be evaluation of the paranasal sinuses for space occupying lesions and inflammatory conditions. So for the Waters view, it is used to assess for facial fractures as well as for paranasal space occupying lesions and sinusitis. So the chin is raised until the mento-mandibular line is perpendicular to the receptor, and the omentomandibular line will be 37 degrees from the receptor. So for the lateral view, it is used to give an overview of the entire skull as opposed to highlighting specific regions. And in this view, we can see the sella turcica well visualized as well as the sphenoid sinus. So for the Towns view, it is the 30-degree fronto-occipital view, and this is part of the standard mastoid series for plain films. It is an AP view with 30 degrees tilt from above and in front, and it is for the evaluation of both sides of the temporal bone, internal auditory canals, and mastoid antrums. And it provides an atrial view of the mastoids. And then for the loss view, this is a 15-degree lateral oblique projection, for which the sagittal plane of the skull is parallel to the film, and the X-ray beam is projected 15 degrees cephalocaudal. Then next we have the Schuller's view, which is a 30 degrees lateral oblique view. It avoids the overlap of impressions of both mastoid bones during images, and separate films of both mastoid bones are taken. So the angle of the X-ray beam leads to superimposition of the views of the internal acoustic meatus and the external acoustic meatus, which leads to separation of the views of both mastoids. And then the Schuller's view is helpful in detection of the extent of pneumatization of both mastoids, as well as the localization of the sinus plate, tegmen, and the sigmoid sinus. as well as the diagnosis of the presence of cholesteatomas. So next we have the stent versi, which is used to demonstrate the petrous temporal bone, internal acoustic meatus, and the bony labyrinth. The beam is directed at a 14-degree angle caudally and 15 degrees posteriorly. Then the modified Senverse view is primarily used to assess electrode placement following the insertion of a cochlear implant. So uh, the obliquity of the beam positions it in a plane of the superior semicircular canal and the 12 degrees cephalic tilt instead of the 14 in the standard Senverse view. So next we have the submandibular vertical, also known as the submentovertical view. This view shows the eustachian tubes, the middle ears, the head of the malleus, the petrous, the external meatai, and an axial view of the mastoid processes. Then next we have the common pathologies. So first we have acute sinusitis. It is an acute inflammatory sinonasal process lasting 4 weeks or less. And then we can see mucosal thickening or opacities within a sinus with or without an air fluid level. Most commonly, it is found in the ethmoid and maxillary sinuses and is typically asymmetric. So chronic sinusitis would be an inflammatory sinonasal process for at least 12 consecutive weeks in duration. So sinus cavity opacification or mucosal thickening with hyperostosis or sclerosis of the bony walls would be the findings in chronic sinusitis. So it is most common in the ethmoid and maxillary sinuses, followed by the frontal and sphenoid sinuses. So CT would have better sensitivity and specificity than plain films. Next, we have the mucocele, which is an expansile lesion. It occurs due to the obstruction of an ostium of a sinus, leading to the accumulation of mucus with potential expansion of the involved sinus. So the accumulated mucus causes increased pressure on bony sidewalls, and on plain films, this appears as complete opacification of a paranasal sinus. So the frontal and maxillary mucoceles appear on plain films as clouding of an expanded sinus with loss of normal mucoperiosteal line of the sinus wall. And then ethmoidal and sphenoid mucoceles may be missed in plain films. So in CT scan, it is better for evaluating mucoceles in these. And then ethmoid mucoceles have the greatest potential for intraorbital extension, while sphenoid mucoceles have greatest potential for intracranial extension. So in frontal mucocele, it extends anteriorly into the skin of the forehead or posteriorly into the anterior cranial fossa. Ethmoid mucoceles may thin and remodel the lamina papyracea, bowing in bowing into the orbit. For maxillary mucoceles, these could expand into the ipsilateral nasal cavity, usually in the area of secondary ostium of maxillary sinus or into the premaxillary soft tissues. Or for sphenoid sinus mucoceles, these may expand anterolaterally into the posterior ethmoids and orbital apex. Then for retention cysts, these usually originate from the obstructed submucosal mucinous glands within the paranasal sinuses. So to differentiate these from mucoceles, the affected sinus usually remains aerated. So they are generally asymptomatic and are dome-shaped, rounded, soft tissues, and they're typically found in the floor of the maxillary sinus, as seen in this picture. So next we have the sinonasal polyp, which are non-neoplastic inflammatory swelling of the sinonasal mucosa that buckles to form polyps. They are uh, so chronic inflammation is a major factor in the development of sinonasal polyps, and they are usually associated with allergies, asthma, primary ciliary dyskinesia, aspirin sensitivity, and cystic fibrosis. It is difficult to differentiate from other space-occupying lesions on plain film, so CT is better to evaluate the extent of polyposis. Next, we have the anthropoanal polyp, which is the most common type of solitary sinonasal polyp. It is a polypoid mass that extends from the maxillary antrum through an enlarged maxillary ostium or accessory ostium into the nasal cavity. It is usually dumbbell shaped in configuration. Then next we have the inverted papilloma. Plain film does not play a significant role in in the assessment of inverted papilloma, but the most common plain film finding is that of a nasal mass with associated opacification of the adjacent maxillary antrum. Typical location is along the lateral nasal wall, centered at the middle meatus. Next, we have the paranasal sinus osteoma, which is a benign, well-defined, slow-growing bone-forming tumor, and they are well-marginated bone density lesions that arise from the wall of paranasal sinuses and protrudes into the sinus lumen. They are more common in frontal and ethmoid sinuses, and they may extend intracranially or into the orbit. So here, larger osteomas may be associated with the following findings. So in the above picture, we can see a large osteoma, and then the CT picture below shows extension, intracranial extension with pneumocephalus. So the larger osteomas may be associated with sinus opacification or mucocele formation from osteal obstruction, orbital mass effect from extraconal extension, pneumocephalus or intraparenchymal tension pneumatocele. And then these findings would be better evaluated on CT since plain film only shows the large osteoma. And then next we have sinonasal squamous cell carcinoma. So these are malignant epithelial tumors with squamous cells or epidermoid differentiation. They are aggressive antral soft tissue masses with invasion and destruction of the sinus walls. 75% arise in the sinuses and approximately 30% arise in the nasal cavities. So most of them arise in the maxillary antrum, while the rest would be in the ethmoid and the frontal and sphenoid. So it usually fills the maxillary antrum, resulting in complete opacification on plain film. So for sinonasal squamous cell carcinoma, the important role of the radiologist would be to create a pre-surgical tumor map of the spread, which is better on CT or MRI. So for medial squamous cell carcinomas, in the extension would be from the nasal cavity into the ethmoid sinuses. For anterior, it would be premaxillary soft tissues of cheek. For posterior, it would be retroantral fat pads, pterygopalatine fossa, and the masticator space. For lateral, it would be the malar eminence and subcutaneous tissues. For superior, it would be through the orbital floor into the orbit proper, or via the pterygopalatine fossa into the inferior orbital fissures, then into the orbits. For the inferior, it would be from the maxillary alveolar ridge, buccal space, and hard palate. And then for perineural tumor spread, it would be through the inferior orbital nerve or the pterygopalatine fossa into the foramen rotundum and then finally into the cavernous sinus. So next we have the sinonasal adenocarcinoma, which are less common than the squamous cell carcinoma. So these are malignant neoplasms with glandular differentiation arising from surface epithelium or minor salivary rests. They have a predilection for the nasal cavity and ethmoid sinuses. So these show us complete opacification of the nasal cavities and ethmoid sinuses on plain film. So the most important link would be the wood dust exposure or industrial dust exposure. In CTMRI, they show up as poorly defined enhancing sinonasal masses within the ethmoid sinuses, nasal cavities, and there could be skull base involvement. So next we have acute automastoiditis, which is the most common complication of acute otitis media, and it is called acute if it is within 4 weeks, 4 weeks or less. And then it is an infection via inflammatory middle ear effusion, freely moving into the mastoid air cells. So on plain film, we can see partial to complete opacification of the mastoid cells, showing clouding or diffuse haziness. Destruction of the intercellular septa is also possible and manifested by loss of the normal trabecular pattern. Next, we have coalescent automastoiditis, which is a term given when bone involvement is present. So we can see progressive bone resorption and demineralization due to intramastoid empyema. Osteomyelitis may or may not be present. So on CT, these show up as rim-enhancing fluid collections adjacent to eroded mastoid cortex with mastoid air cell opacification. And then enhanced temporal bone MRI would be more sensitive for intracranial complications such as dural sinus thrombosis, meningitis, subdural empyema, and parenchymal abscesses. Then chronic mastoiditis would be automastoiditis of at least 12 weeks. So it is primarily due to eustachian tube dysfunction, and the decreased intratympanic pressure is the most likely the basic predisposing factor. So complications for chronic automastoiditis would be ossicular erosions, tympanosclerosis, typical apical petrositis, granulation tissue formation, abscess formation, cholesteatoma, brain abscess, and epidural empyema. So lastly, we have cholesteatoma, which are aggregations of desquamated keratinizing stratified squamous epithelium forming a mass. They may be congenital or acquired, and then on plain film, they show up as opacification of the involved mastoid with cavitation. So they may be complicated by massive bone destruction, which can lead to exposure of the dural membranes. And superimposed acute infection can accelerate the destructive processes via the effect of the osteolytic enzymes, which are secreted by the epithelial cells as a response to the inflammatory process. Thank you.
Thank you, Nico. Any chance? No, so ano ba't natin inaaral ng maths and TNA, temporal bone, kasi part siya nung ano, ng X na. And it's very difficult to give a diagnosis if you don't know what you looking at. No? So, medyo dapat tayo pa paano ipakita. Hindi tayo kung ano lang yung gawin ng tech, pinibigay sa atin, but actually hindi naman optimal talaga. No? So, for those who will be taking the board, the future, no, if they use pag caldwell, anong angle, no? Frontal AP, ano ba? So, waters, what angle? I'm not sure about the recent PBR exam, but during my PBR 1 exam, puro ganun yung questions. Sa CT, meron din. Sino ba CT rotator? CT senior. Wala. Yung sumagot.
Doc Pads daw po,
Ah,
sir.
okay, sige. Pads and Waldy yan. No? And kung nandiyan din si Jack, no? So, may na-encounter na ba kayong request sa CT scan na temporal bone width transverse view? Ikaw, Butch, may na-encounter ka na? Yung resident ka?
Ako, Doc.
Ba't kaya may echo? Hello? Turn on nyo naman yung camera nyo, please.
Ay, akala ko naka-on. Sige.
Sino naka-encounter na? Ikaw, Jack?
Wala po, Doc. No first year ako.
So may ganung view transverse view at saka ano, yung iba tawag doon, Koshol. COSCHL, Koshol's view. So try to read on those views, no? So views siya na ang focus are na kasi we're used to reading the images based on how it was presented to us by the technologies. So, eggshell, especially for CT, eggshell, coronal, sagittal, no? But actually, you can do oblique eggshell views, no? So, ang tawag doon, ano, yung oblique eggshell view, it's called your Stenverse view. So, though meron Stenverse view sa X-ray, iba siya. dun sa Stenverse view sa CT, no? It's a way to really show the 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 entirety of the cochlea, no? Kita mo from basal up to the apical turn. Then perpendicular to your Stenverse view, you have your Poschol's view, no? Poschol or Poschol's view, no? Ano naman siya? Perpendicular siya. So yung Stenverse view, it's a plane wherein yung cut mo is perpendicular to the petrous apex. Pero pag Poschol, it's perpendicular, no? So yung Poschol's view, it's a coronal oblique na cut to better delineate the superior semicircular canal. So if you're going to look for superior semicircular canal dehiscence, that's a good plane, no? Ano yan, hindi tech ang gagawa niyan, tayo, no? So we can angulate it. We can do an MPR reconstruction para makuha yan. Pero kasi if the attending physician requests for that view, dapat yung tech may mapapakitang ganong image. No? So, trabaho na ng resident, no, or ng consultant to tell the technologies which views or which images should be provided to the patient. No? So, try to read that Stenverse, no? Mas common yung Stenverse, yung Poschol, medyo hindi masyado nila nire-request. Any questions for Ay ako, may question pala. Nico, baka na-encounter mo yun. The city readers, no? Feedback eh. Kahit isang lang. Nico, pads, and sino yung isang city rotator. How will you, kasi minention ni Nico na an antroquanal polyp is a dumbbell-shaped lesion wherein the neck is along the osteomeatal, the maxillary ostium, and areas of widening or expansion within the what do you call this maxillary antrum and the nasal cavity. How would you differentiate an inverted papilloma from an antroquanal polyp? Pareha sila based dun sa picture ni Nico. How will you differentiate between the two?
Doc, on lateral X-ray, we can see that the antrochoanal polyp has extension into the pharynx, the pharyngeal region.
It would depend on the size, no? But instances, an antroquanal polyp, yung the medial side would only extend within the nasal cavity mismo, no? Pwede naman pag super laki, pero halimbawa, ganun, pwede rin kasing gawin ng inverted papilloma yun, no? May naka-encounter na ba sa inyo nang nag-diagnose ng inverted papilloma?
Wala pa ako. Puro antroquanal.
Ako isang beses ko pa lang siyang nire-read dati. No? Can you pull out the image, Nico, ng yan, malaki kasi ang antroquanal polyp na yan, Nico, no? Sa pharyngeal area. But you have a small one, how would you differentiate, no? So, pull out mo yung image mo ng inverted papilloma. Ba't ba inverted papilloma tawag sa kanya? Sige nga.
Yung direction, Doc, going downwards.
Going downwards
From the
or
root
going... sige, tama. Nico,
From the roof going downward.
Saan nag-originate ang inverted papilloma?
Along the lateral nasal wall.
Okay.
At
So,
yeah,
you're right, no? So, technically, it originates from the nasal cavity, extending into the nasal maxillary ostium ay antra. Okay? Kaya siya tinawag na inverted papilloma. Baliktad eh. Ang antroquanal polyp kasi nag-umpisa sa maxillary antrum, go outside. Ito baliktad, pumapasok sa loob. Okay? Oh. So ito this is one of the easiest way to differentiate between the two. Okay? Ang antroquanal polyp, pupunuin muna niya ang maxillary sinus bago siya pumunta ng nasal cavity. Okay? So balik ka doon sa unang picture mo, yung antroquanal polyp. Yan, oh. Pinuno mo niya yung antral, yung antrum bago siya lumabas. Okay? Ang inverted papilloma, baliktad, pwede niyang hindi punuin yung yung maxillary antrum. Pwedeng party. So balik ka dun sa picture mo ng inverted papilloma. Yan, oh. Tignan mo, pinuno muna niya yung nasal cavity dahil dun siya galing, nung wala na siyang mapuntahan, tsaka siya pumunta ng maxillary. Nakuha niya?
Yes, Doc.
Okay, oh. So, ba't siya kailangan ma-differentiate? No? Actually, kasi yung inverted papilloma, alam ko, may increased risk yan na magkaroon ng what do you call that syndrome? Silent sinus syndrome. Yan. So, try to read on that, no? Dahil nabarahan niya yung labasan, nagkakaroon ng vacuum yung labasan ng yung maxillary osseum, dahil nabarahan niya, nagkakaroon ng negative pressure sa loob ng maxillary sinus. So, ang nangyayari, nag-shrink siya. No? So, ang tawag doon, silent sinus syndrome. Tama. Yun ata ang tawag doon. Okay? So, that's one way of differentiating between the two. So, halimbawa, meron kayong, lagi tayong pinakol, antroquanal polyp, kasi nakita mo, widened yung maxillary ostium, tapos meron kang dumbbell-shaped lesion. Always look at the rest of the maxillary. If it's completely filled, most likely you're looking at antroquanal polyp. Pero if it's not, partially filled lang siya, no? Most likely it's an inverted papilloma. Okay?
May question
important. Sino yan? Jack?
Opo.
Okay,
Dok,
sige.
pareho ba sila na may halimbawa osteolytic ng osteolytic changes to the halimbawa yung bony
Okay,
surrounding bones.
no? Actually, that's a good question, no? Technically, if there
Nawala din ako ko.
at saka inverted papilloma and any nasal disorder would just give you mass effect. So if
Dok, nawawala ka.
Maxillary sinus wall, it would expand. Wala ako. Wait lang ha. Nalobat na ako. Medyo may na internet ko, sorry. How about now?
Okay po.
Technically, Jack, wala siyang, if you're going to be strict dun sa definition, dapat wala siyang osteolytic changes. Hello?
Kasi then you would entertain malignancy, Doc.
Yes. Doon na pumapasok kung bakit ang basa minsan cannot totally rule exclude squamous cell carcinoma, no? Ang polyps mass effect lang. Lalaki ang maxillary ostium relative to the other side, lilipat or mai-indent yung mga concha, no? Middle, superior and inferior concha. The walls of the nasal cavity and maxillary sinuses pwedeng mag-bow, whichever kung saan yung mas mass effect. Yun ang itsura ng papilloma at saka nasal polyposis. So, pag meron kayong nakitang completely opacified na maxillary sinus and nasal cavity, always look for signs of mass effect. Pag walang masyadong mass effect, most likely you're just looking at a congested nasal cavity at saka acute maxillary sinusitis. No, kung may lytic changes na medyo baka more on squamous cell carcinoma. Okay? Ang isa bang pwedeng magbigay ng mass effect, Jack, mucocele, no? But mucoceles, mucoceles, no? So minsan kasi lahat ng nakikita natin sa sa maxillary sinus, ang basa natin basta bilog, mucus retention cyst, di ba?
Opo.
Ang mucocele may mass effect siya. So tignan mo din sa x-ray na pinakita ni Nico. Medyo expanded, di ba? Yung right maxillary antrum. No? So that's one way to differentiate. So if you have, ito pa, yung schematic drawing niya ng, ano ba to? Frontal at saka anterior ethmoid, no? Expanded yung sinus cavity, no? So that's one way to differentiate between a mucocele and a mucus retention cyst. And by incidence talaga mas common sa frontal sinus ang mucocele. So pag may expanded ka na frontal sinus, think of a mucocele. Okay? At saka ito, recently ko lang natutunan, di pala tumutubo sa nasal septum ang polyp. So if you have kay Chilen ko natutunan yan. Kasi di ba cartilage siya. So poor vascularization siya eh. So if you have a rounded structure emanating from the septum, most likely you're just looking at a mucus retention cyst and not a polyp. So wag daw i-call na polyp yun.
Okay po.
Any other
Yes, po.
questions?
Doc, paano kapag polyposis? Paano pag marami ng involved na sinuses?
Basta
Safe ba yun i-call?
Yeah.
Pwede pa
Kasi
rin.
ganito pare. Ako wala akong problema with calling nasal polyps. Alam mo kung bakit? Kasi yung nasal polyps, kinokol na kaagad yun ng ENT. Kasi kita nila yun eh.
Okay.
Diba sinilip nila yung ilong? Ang problema kasi pare, hindi nila kita yun sa loob ng sinuses. Kaya hindi nila pinapasitis ka ng pasyente para malaman kung may nasal polyp. Kasi alam nila may nasal polyp eh. So, ang gusto nilang malaman kung may component ba yung nasal polyposis antral.
Okay.
Nakuha nyo? Kasi pag may antral component, ang hirap mag-drain. Hindi na-drain yung secretions ng maxillary sinus.
Kasi barado.
Ng nasal cavity because of the... kasi barado eh. Ako, medyo, pag sinabi ng ENT, lalo na kung ENT yung doktor, tapos nilagay niya nasal polyposis, tapos nakita mo completely opacified yung nasal cavity, mandaya ka na, lagay mo na lang nasal polyposis pa rin.
With extension na lang, yun na lang po.
Oo, yun na lang, bigyan mo ng additional information. Kasi pag sinabi ng ENT na nasal polyposis yan, pare, hindi mo na pwedeng contrain yan. Kasi nga, nakita niya yan eh. Nasilip niya yan sa scope eh. Ang hindi niya kasi kayang gawin, isilipin beyond the maxillary ostium and within the the antral cavity, the maxillary cavity. Kasi hindi umaabot yung scope din. Yun na naman ang problem niya. And siguro, siguro ang additional information na pwede mong sabihin is if the nasal cavities are completely obstructed, is it extending to the nasopharynx? Yun na lang siguro. No?
Okay, Doc.
Basta ang importante, always look for mass effect. If you see mass effect like this one, tingnan mo yung nasal polyposis na itong picture na pinakita ni Nico, expanded yung maxillary sinus. So alam mo may antroquanal component. Tapos, hindi ko na masyado makita yung kung nasaan yung mga
Osteomeatal unit.
Mga concha no? At saka yung concha, hindi mo na makita, no? Again, yung concha, those are the bony structures. If you're pertaining to the mucosal lining, the concha, that's called the turbinate. No, yung bony part, it's called the concha, but the mucosal part, the soft tissue part, that's called the turbinate. So if you're going to be about hindi siya parehas, no? Kaya concha blosa, di ba? Yung concha, yung bonus or pneumatis. Okay? Any other questions? Mahirap mag-ano ng ENT. PNS, siya eh. Medyo maganda talaga nakakausap niyo yung ENT kasi sometimes we give diagnosis medyo bogus na parang hindi naman dapat natin i-read. So that's a good thing to communicate with them. Okay? Sige, who's the next lecturer? Si Ana ata si Enzo, no?
Hello?
Yeah.
Hello, rinig po ba ako, Doc?
Yes, pare.
Ah, hello?
Yes. Oh,
Yes, rinig po ako, Doc.
rinig. Oo, rinig.
Okay. Sige po, Doc. Wait lang po. Nasaan? Ay.
Ayaw mo.
Yeah, but this makes it more mangyari tayo. So, paano nga
Hello, good morning po. Today I will be presenting po regarding thyroid ultrasound and thyroid pathologies. So, of all the modalities that we use here sa radiology, ang ultrasound is actually the first and the best modality to image thyroid pathologies because it provides the highest resolution and therefore is best able to detect and characterize diffuse and focal thyroid abnormalities in high resolution. Aside from that, it can also be used for real-time biopsy procedures. The patient, ang ginagamit natin na probe dito is yung linear array transducers ranging for 7.5 to 12 millihertz. And the position of the patient is placed in supine position with the neck mildly hyperextended. Even if siya yung primary imaging modality, may limitations tayo with regards to use of ultrasound. And the number one factor would be the high degree on operator skill. So nasa technique siya, nasa nagsascan yung magiging sensitivity ng scan natin. And the inability of the sonographer to detect vetotracheal and intrathoracic extension of an enlarged thyroid because of overlying air or bone. In which case, dito lumalamang yung CT scan. And then, sa pangatlo naman, there's limited in detecting extension of thyroid malignancy into the adjacent trachea, esophagus, and other adjacent structures of the head and neck. Again, mas lamang ang CT scan when it comes to these kinds of problems. So, basic anatomy ng thyroid gland. The thyroid gland is located in the upper margin near the oblique line of the thyroid cartilage and its lower margin, a region referred to as the thyroid belt. So, here is, kita ba yung mouse? Kita yung mouse. So, ito yung usual anatomy ng thyroid gland natin. The letter C would correspond to the internal carotid artery and the J would correspond to the internal jugular vein. And then yung TR is yung trachea, and ito yung isthmus, right lobe, and yung left lobe. And then, sa harap naman niya, yun yung strap muscles natin. Sa OR, ito yung unang muscles na na-operahan. Tapos sa tabi naman nun, doon naman yung sternocleidomastoid muscle. And one important landmark para mahanap yung thyroid is yung longus colli muscle, which is in this area. So 10 to 40% of patients would have a small pyramidal lobe arising superiorly sa isthmus. So ito, and laying in front of the thyroid cartilage. So some normal details, the normal thyroid gland weighs around 15 to 35 grams, and in males, the average thyroid volume is 19.6 ml, whereas in females, it is 18.6 ml. The isthmus averages 12 to 15 millimeters in height. The average thyroid volume measures 3 cm in greatest AP diameter, 2 cm in width, and 5 cm in height. And it lies anterior to the prevertebral or longus colli and paraspinal musculature. So among sa 3 dimensions ng thyroid, ang pinaka-important and reliable measurement dyan is yung AP diameter. So ito yung AP, ito yung width, tapos ito naman yung height pag chinek sa long section. Oops. So we start off with some pathologies na. So we start with developmental anomalies. So some basic developmental period ng thyroid. It starts at the first trimester around the 5th week of gestation and is usually complete by the 10th week. So, nagsa-start yung thyroid sa foramen cecum, sa base ng tongue, and magde-descend siya sa lower neck as its final destination. So, during the caudal descent of the gland, the duct elongates and usually it degenerates. So, ano mangyayari if hindi bumaba yung thyroid gland sa foramen cecum? Then we will have what we call yung lingual thyroid. So, kita dito sa CT scan, ito siya. It's a hyperdense enhancing midline mass sa position of foramen cecum, and better appreciated sa sagittal view. Nandun yung lingual thyroid. And majority of these lesions are non-functioning. And yung next naman na one of the most common developmental anomalies ng thyroid gland is yung thyroglossal duct cyst, and this results from the incomplete degeneration of the thyroglossal duct, wherein it is clinically seen as an anterior neck midline mass that moves with swallowing or tongue protrusion. Majority of the lesions are seen infrahyoid. So we have some pictures dito that would delineate yung mga itsura ng mga thyroglossal duct cyst. So this one is at the level of the hyoid bone, wherein it shows a well-defined cyst behind the hyoid bone. So letter B naman, it is seen at the inferior margin of the hyoid bone. And then sa letter C naman, it is seen in the infrahyoid region, yung thyroglossal duct cyst natin. And sa ultrasound, as with all cystic structures, it would be seen as a thin wall fluid-filled anechoic focus. So important na makita siya kasi clinically, even if asymptomatic yung mga ganitong klaseng lesions, pwede sila, ma-infect. Pwede sila ma-infect and would actually cause symptoms para sa pasyente. Then yun din na ginagawa yung tawag sa procedure, yung cyst-trunk procedure. So, stop sa mga usual pathologies ng thyroid gland. Start off sa Graves' disease. It is the most common autoimmune disorder wherein the thyrotropin receptor on the follicular cell is the target for thyroid autoantibodies that bind to these receptors, stimulating them as though TSH triggered the receptor. Most common siya sa 3rd to 4th decade and with female predilection, and usually may hyperthyroid yung mga pasyente. So here are some pictures of yung images ng Graves' disease. So dito sa first picture is a radionuclide scan wherein the thyroid gland is diffusely enlarged with intense radio tracer uptake, often as high as 80% in 24 hours. And we have the second image, so kitang-kita yung sobrang taas ng vascularity ng thyroid gland. So ito yung tinatawag nilang thyroid inferno, wherein the severity of which tends to parallel the patient's degree of hyperthyroidism. And then sa CT scan, doesn't really help much masyado. Usually makikita mo lang na enlarged lang talaga yung thyroid gland. And ito naman yung MRI imaging features wherein dito sa asterisk is yung enlarged thyroid gland. So next one we have is yung Hashimoto's thyroiditis. It is the prototype autoimmune thyroiditis wherein pathologically pathologically there is lymphocytic and plasma cell infiltration, follicular cell atrophy, and interlobular fibrosis. And once the follicular cell atrophies, it can be replaced with pink oxycytic epithelium, yung tinatawag nating Hurtl cells. Then autoantibodies have also been identified against thyroglobulin, peroxidase, and TSH receptors. It usually occurs sa 4th to 5th decade of age and with also female predominance. So, ang usual appearance ng mga Hashimoto's thyroiditis would involve multiple sub-centimeter micronodules, which are hypoechoic and usually surrounded by mildly echogenic. So, marami kang makikita mga micronodules dito. Ito. So, usually, parang heterogeneous na rin yung itsura nila. And then, dito naman sa CT scan, it shows a moderately enlarged thyroid gland with a mottled, slightly non-homogeneous appearance. So, yeah. Puro tudok sila when it comes to imaging. And when it comes to ultrasound naman din, usually pwede siya maka-help in detecting occult malignancy because even if rare naman siya, there is a known increased risk for non-Hodgkin's lymphoma sa mga patients with Hashimoto's thyroiditis. So, next one is yung subacute lymphocytic thyroiditis. May dalawang type siya. We have yung silent painless thyroiditis and yung postpartum thyroiditis. Pag hindi buntis, silent painless. Pag buntis, postpartum. Usually, self-limited lang to. And this is important in differentiating sa Graves and kasi sa Graves, usually kailangan mo ng aggressive treatment for that. Whereas sa subacute lymphocytic thyroiditis, self-limited lang siya, so no need for aggressive treatment. So it is clinically seen as a thyrotoxicosis that progresses to transient hypothyroidism before returning to a new thyroid state. Radioactive uptake is low. And yung postpartum thyroiditis, this usually happens 46 weeks following delivery, and it involves 5% of delivery. So bihira lang naman siya. Pero ang problem kasi dito, pwede siya mag-progress sa Hashimoto's thyroiditis. So this is a picture of a CT scan wherein there is an enlarged right thyroid gland lobe which has a lower attenuation than the left lobe. And then we have yung decurvent thyroiditis or yung tinatawag natin subacute granulomatous thyroiditis. Ang difference naman nito is usually sa history ng pasyente, it follows a viral upper respiratory tract infection involving yung Coxsackie or yung mumps. Second to fifth decade ang usual age involvement with female predominance wherein it is clinically seen as painful enlargement of the thyroid gland with fever and thyrotoxicosis with low radioactive iodine uptake. And one of the key features ng itsura nila is that may mga micro abscesses sila sa imaging. And next one is yung acute suppurative thyroiditis, which results from seeding of the thyroid gland by bacterial and occasionally fungal organisms in immunocompromised and or debilitated patients. Maybe pag may ganito, usually associated sila sa mga bronchial cleft abnormalities, and the role of imaging is to exclude a fistula, especially galing sa piriform sinus as an etiology of the thyroiditis. So here is a picture of an enlarged left thyroid lobe with a focal abscess in a 6-year lobes in the anterior lobe. So every time na may abscess sa mga ganito, pwede ka rin maghanap na you should consider a possibility of a brachial cleft cyst abnormality. And next one is yung radial thyroiditis. It is a fibrosing reaction that destroys the thyroid gland and extends to the adjacent soft tissues of the neck, wherein etiology niya is unknown and involves a 4 to 7 decade with female predominance. So here are images of some of yung radial thyroiditis. Kung mapapansin mo sa ultrasound, sobrang hypoechoic ng buong thyroid gland. Sa CT naman, hypodense siya, super hypodense siya as compared sa normal thyroid gland. And sa MR naman, decreased yung signals niya on T1 and T2 weight images. So sa thyroid goiter, actually, goiter would just actually mean an enlargement of the thyroid gland. Marami-rami kasi siyang types, so isa-isahin natin. So meron tayong simple nodular goiter. Usually, ang tinatawag siyang simple nodular goiter pag walang pag may absence of autoimmune disease, thyroiditis, thyroid dysfunction, and thyroid malignancy. And then, if diffuse non-toxic goiter, non-toxic, so ibig sabihin yung thyroid yung pasyente and buong thyroid gland is enlarged. Pag tinawag naman natin endemic goiter, when 10% or more of the local population has a goiter, doon na siya tinatawag na endemic. Usually, these areas are usually away from the oceans, in iodine-poor areas, and there is not only a high incidence of goiters, pero matataas din ang incidence ng anaplastic thyroid CA sa mga patients, sa mga lugar na may endemic goiter. Ang problem kasi sa kanila, pag binigyan mo sila ng iodine bigla sa diet, the incidence of goiter and anaplastic carcinoma decreases. However, yung papillary CA naman would actually, the papillary CA incidence would actually increase. So next naman sa simple sporadic goiter, wherein there's female predominance, wherein there's peak incidence at puberty, and then over time, magpo-progress sila usually sa multinodular goiters. And then lastly, multinodular goiters would involve nodularity, focal hemorrhage, focal calcification, cyst formation, and scarring. So here are some images of yung mga goiters natin. So here we have a huge non-homogeneous goiter, mas malaki yung right kaysa sa left. Ito rin, enlarged din yung thyroid gland natin, pero left naman yung mas malaki with compression ng trachea. And then ito naman is moderately enlarged multinodular goiter. May adenoma dito sa anterior isthmus. And then this one, an enlarged non-homogeneous thyroid gland with the left thyroid gland extending up behind the esophagus level. So nakikita ko makalat yung thyroid gland sa likod ng esophagus. So we start naman sa some malignancies ng mga thyroid pathologies. Usually, ginagamit natin yung thyroid score whenever we try to give our reports sa ultrasound dito. Pero it's not within my discussion kasi di-discuss ni Christian po mamaya. However, discuss na rin natin yung some basic malignancies ng thyroid pathology. So yung pinaka-common is yung papillary carcinoma. It is the most common and it is has the best prognosis sa kanilang lahat. So it is the most common malignancy of the thyroid wherein it spreads through the lymphatics. So yung lymphatics yung keyword dito. And isa pang keyword dito is may highest incidence of cervical lymph node metastasis. So pag mataas ang suspicion na may papillary CA yung pasyente, better yet makita na rin yung mga cervical lymph nodes for possible metastasis sa areas na yan. So it is described as an hypoechoic nodule with solid echo texture with microcalcifications and intrinsic vascularity. So ganito yung itsura niya usually. So here are some images ng papillary CA. So as kita dito sa taas, brief lang. Ito, may cervical lymph node dito, metastatic right lymph node. Tapos dito naman, may solid lymph node na may vascularity. So sa CT scan images naman, there is a mass in the thyroid lobe and an almost completely cystic metastatic right level 4 lymph node. Ito pala. Sorry. Yan. Ito yung mga lymph node, and mass sa CT scan. So sa follicular CA, usually solitary sila, slightly more aggressive than papillary CA if vascular invasion is present. However, mahirap siya differentiate through imaging alone and kailangan talaga ng pathology because one of the important pathological marks ng follicular CA is yung capsular and vascular invasion. Pero other than that, usually ang common sa kanila, nagsispread sila hematogenously. And yun, distal hematogenous metastasis na lang is common. So ito yung region ng paano siya kumakalat based sa pictures dito sa ilalim. So medullary CA, it arises from the parafollicular C cells, wherein yung parafollicular C cells na nagsisecrete ng calcitonin, kaya isang magandang marker sa kanila is yung calcitonin pagdating sa labs. So may dalawang type sila, may men type 2A, men type 2B. And pag binigyan mo sila ng radioactive uptake, hindi sila nag-concentrate ng radioiodine. So dito sa picture sa lower left, there is a low attenuation mass in both thyroid lobes. On the left side, no peripheral rim of the thyroid gland is seen posteriorly, and this raises the possibility of early violation of thyroid capsule. And then sa mass naman, sa kanan, the mass is poorly benign. Actually, ang hirap i-differentiate as compared sa ibang thyroid malignancies. Kaya kailangan talaga din ng biopsy. And other laboratory parameters. So this one, ito naman, is a fixed left neck mass with a large infiltrating tumor arising from the left lobe of the thyroid gland with posterior extension outside the thyroid capsule into the prevertebral muscles. And then lastly, yung pinakamalala sa kanila is yung anaplastic CA, wherein it usually occurs to older patients, highly aggressive and fatal, commonly occurs with long-standing goiter, and it grows rapidly and typically compresses and invades the aerodigestive tract and vessels. So to give a brief overview ng itsura ng mga anaplastic CA, usually necrotic, infiltrating talaga, and malakas, sobrang kumakalat sila sa adjacent structures, as you can see sa mga images dito. Thank you.
Thank you, Enzo. Any questions for... Rinig ako, Enzo? Rinig ako?
Rinig po, Doc. Rinig po.
Any questions for Dr. Enzo? Ako, Enzo, may question ako.
Yes, Doc. Ano po yun?
Ito medyo important to, no? So you mentioned that the most superficial structure are one of the more superficial structures sa thyroid area is your strap muscles. Ano yung dalawang strap muscles na yan?
Yun yung sternothyroid.
Actually,
omohyoid?
Actually, omohyoid part din siya, pero overlying the thyroid tissues. Sternothyroid and
myohyoid. Sternothyroid
saka sternohyoid.
Hyoid.
Okay, no? So, but importante yung strap muscles kasi if the kasi mamaya i-discuss ni anong tawag nito, ni Christian yung thyroids no? So sometimes you need, most of the times pala, it's easy to say if the lesion is hypo, hyper, no? But what if the thyroid is diffusely hypo? Ano nang tawag mo dun sa lesion? No? Ako kasi kino-compare ko palagi yung thyroid nodule, yung echogenicity niya based on the adjacent strap muscles. Hindi reliable na yung thyroid palagi. Same thing with ganito. Halimbawa, meron kayong hypoechoic nodule, meron kayong hyperechoic nodule, then sa liver, then the liver has a background of fatty liver. Di ba minsan pare ang hirap mapansin? Kasi hyper on hyper, no? Parang it's putting white paint in a white wall, no? So one way to help you with pag sa case ng thyroid is to compare it with the strap muscles. No, kaya siya laging binabanggit, no? Tapos yun, importante yung sinabi ni Enzo na yung sa Dequer veins, tender or painful, no? So you can ask the patient, masakit po ba? No, kasi lagi tayo Hashimoto lagi ang diagnosis natin. Pero actually, siya kasi yung pinaka-common, no? If you have thyroiditis, it is usually Hashimoto's thyroiditis unless proven otherwise. Okay? So you ask the patient if may pain, kung tender yung area, most likely you're looking at Dequer veins. Okay? Isa pa, Enzo, you mentioned about thyroglossal duct cyst, no, which is a midline cystic lesion, no? Sa infrahyoid area, it is midline, but in the suprahyoid, it could be paramedian. Ibig sabihin, pwede mag-deviate from left or right, no? To the left or to the right. What's the most common differential diagnosis for a thyroglossal duct cyst? And one way to differentiate them is itong isang lesion na to, it's always paramedian. Ibig sabihin, not within the middle, hindi sa gitna. Kasi usually, itong structure na to, congenital, bilateral kasi siya eh. Kaya usually nasa magkabilang side. Any idea? Other ultrasound rotators or seniors?
Branchial, Doc.
Yan, bronchial cleft cyst, no? So, aralin nyo lang yon, first, second, third, fourth, no? So, may mga typical, but I think the most common is still your second bronchial cleft cyst. No, so if you have a anterior neck cystic structure in a young patient, kung pwede, laging ganun yung differential diagnosis nyo, no? Lalo na kung suprahyoid, above the hyoid, no? It's either a thyroglossal duct cyst, cannot totally exclude the possibility of a second bronchial cleft cyst. Okay? Any
Okay po,
question
Doc.
for Enzo? Okay? Sige, next, Christian?
So, good morning, everyone. I will be discussing ACR thyroid imaging reporting and data system, or ACR ThyRADS. So, it is a reporting system for thyroid nodules on ultrasound proposed by the American College of Radiology. So, this uses a standardized scoring system for reports, providing users with recommendations for when to use fine needle aspiration or ultrasound follow-up of suspicious nodules, and when to safely leave alone nodules that are benign or not suspicious. So scoring is determined from 5 categories of ultrasound findings, namely composition, echogenicity, shape, margin, and echogenic foci. So the higher the cumulative score, the higher the thyroid's level and the likelihood of malignancy. So for the first category, the composition, so 0 points if the findings in thyroid ultrasound is cystic or almost completely cystic. So if you see cystic nodule, it will automatically be categorized as TR1. So no further points will be added. So next is 0 points again if it is spongiform. So just like cystic lesion, if you see spongiform nodules, it will be automatically categorized as thyroids 1. So for mixed cystic and solid nodules, 1 point. So for solid or almost complete.
Sorry, Christian, for the benefit of those who haven't rotated sa ultrasound, can you explain to them ano ibig sabihin pag spongiform?
Ito po, sir. So pag sabi pong spongiform, may mix po ng solid and cystic structures po, sir.
Hindi complex yun. By definition, complex lesions are mixed fluid and solid components. So what would be a good way to describe a spongiform nodule? Like a sponge. Tama, no? So technically, it's like sponge. You have a somewhat solid lesion, but within the solid lesion, you see compartmentalized fluid component. No, just it's wording lang. Kasi looking at the image, you know that it's really spongiform, no? But for
Yes,
those
po.
who haven't rotated sa ultrasound, sasabihin nila, ba't anong kaiba ng complex diyan? So it's like basically it's a solid lesion, no? For me, it's a solid lesion wherein you have lots of compartmentalized fluid structure. So siguro that's a good term, no? May mga compartments na parang may fluid sa loob. No? Dati kasi binabasa to, Christian, 3-4 years ago, you won't hear the term spongiform. You can ask Dr. Manny. Manny, nandyan ka pa ba?
Yes, Doc.
Manny,
Opo.
when you were a first year na nag-rotate sa ultrasound or yung pa-second year ka, na may consultant ba sa atin na mahilig gumamit ng spongiform?
Parang di gaano.
Wala no? Nung nauso lang ang ACR thyroids, saka sumulpot yan. Dati, lagi ang description namin sa ganito, complex.
Complex.
Ang clinician dati, pag narinig nila yung term na complex, takot na sila eh. But eventually, this was disproved by ACR na these are just benign lesions, no? So again, just to differentiate between spongiform and complex, no? Okay, sige. Thank you, Christian. Continue.
Thank you po, sir. So again, for mixed cystic and solid, 1 point. Then for completely solid or almost completely solid, we assign 2 points po. So next category is echogenicity. So for anechoic, we assign 0 points. So hyperechoic or isoechoic is 1 point. So for hypoechoic lesions, we assign 2 points and 3 points for very hypoechoic nodules. So for shape, we usually assess the shape of the lesion on transverse plane. So if the lesion is wider than tall, it is usually assigned 0 points, and then 3 points for taller than wide. So next is for the margin. So if the nodule has smooth margin, it is assigned 0 points. So ill-defined is still 0 points. So for lobular or irregular margin, it is assigned 2 points. And for extrathyroidal extension, it is assigned for 3 points. So the last category is for the echogenic foci. So hindi katulad ng iba, yung echogenic foci, pwede siyang accumulated. Pwede kasi siyang magkaroon ng one or more of the following characteristics. So kapag wala or large comet tail artifacts, 0 points. So for macrocalcifications, 1 point. So peripheral calcifications are assigned 2 points, and punctate echogenic foci are assigned 3 points. So when all points are added from all categories, so 0 points is thyroids 1, which is benign. So no fine needle aspiration is needed, and it has 0.3% risk for malignancy. So 2 points is thyroids 2. So it is not suspicious, still fine needle aspiration is needed, and 1.5% risk for malignancy. So for 3 points, it is thyroids 3, which is mildly suspicious. So we have to do fine needle aspiration if the lesion is more than equal to or more than 2.5 centimeter, and follow up if 1.5 centimeters and above. So it has 4.8% risk for malignancy. So if the accumulated score is 4 to 6 points, it is categorized as thyroids 4, which is moderately suspicious. So if the lesion is equal to or more than 1.5 centimeters, fine needle aspiration is recommended. But if it is equal to or more than 1 centimeters only, follow-up is recommended. So it has 9.1% risk for malignancy. So for 7 points or more, it is categorized as thyroids 5, which is highly suspicious. So for lesions that is more than or equal to 1 centimeters, fine needle aspiration is suggested. And follow up if it is more than or equal to 0.5 centimeters. It has 35% risk for malignancy. So for example, as discussed earlier, if the lesion is spongiform or cystic, it is automatically categorized as thyroids 1. So for this lesion in yung encircled, so it is solid. So it is iso to slightly hyperechoic. So it is given additional 1 point. It is wider than tall with smooth margin and no echogenic foci. So it has accumulated points of 3. So it is Tyrans 3. Mildly suspicious. So again, fine needle aspiration if more than 2.5 centimeter and follow up if it is more than 1.5. So next example is again solid, so which is given 2 points. Hypoechoic, so another 2 points. So wider than tall, 0 points with smooth margin and no echogenic foci. So it has an accumulated score of 4 points, which is Tyrans 4, which is moderately suspicious. So for the last example, it is a solid lesion, which is 2 points. Very hypoechoic, which is 3 points. Taller than wide, another 3 points, and with extrathyroidal extension, another 3 points. So with a total of 11 points, this lesion is categorized as thyroid 5, which is highly suspicious. So, ayun lang po. Thank you.
Okay. Christian, may question ako.
Yes po, sir.
How will you differentiate what's the sonographic appearance of a comet tail artifact in microcalcification? Kasi both are echogenic, no? Hindi ko, no? So hindi pa sino pa ba hindi nagro-rotate? Si ano pala? Si Noel, hindi pa, no? So calcifications and comet tail artifacts both would appear as echogenic or bright sa ultrasound. So how would you differentiate between the two? Para kasi ang layo no? I think ano bang score ng micro-punctate echogenic foci or microcalcification sa thyroids? 3 points ba? 2. Sorry na
ang macro po is ano po sir, 1 point. Ang peripheral is
so 3.
3 ang punctate po.
Okay, so how will you differentiate between the two? Para kasi layo from 0 magiging 3 no? Hello? Wala ba ako?
Sila yata yung nawala, Dok. Nawala yan. Ay, nakamute yata.
Nakamute yata. Ano? Hello? Christian, rinig kami? Sorry
Yes, masarap po.
So how will you differentiate? Kasi nag-ultrasound ka na, baka mamaya pinapakita ninyo. Kasi ang comet tail artifacts that finding is very characteristic of a colloid cyst, no? So colloid cysts are considered benign thyroid nodules, no? In contrast to a nodule with calcifications, no? So paano ba? Even for gallbladder cholesterolosis or adenomyomatosis, no? You have comet tail artifacts. Paano mo nasabing comet tail artifact yun at hindi calcification? What's the sonographic characteristic? Call a friend. Sino ultrasound? Yung partner mo doon, si Enzo. Enzo.
Ultrasound friend.
Sir, nagte-taper daw po, sir, pag comet tail.
Nagte-taper. Yeah, you're correct, no? Nagte-taper ang alin?
Ang comet tail po, sir.
Ang comet tail. Sige. Pag calcification,
Shadowing.
Yun. Actually, that's the answer, no? Calcifications would give you posterior acoustic shadowing. A comet tail artifact would give you dirty, not really dirty shadowing. It would give you posterior attenuation. When you use the term attenuation, ibig sabihin tumataas yung echogenicity, no? So that's also one way to I mean, for comet tail artifact sa gallbladder, no? Nakikita mo, di ba? Nakakita ka na yun for sure, Christian, ng comet tail
Yes,
artifact sa gallbladder. O, di ba nakita mo? Hindi itim yung likod. Ano yung likod
yes.
nung focus? Di ba bright, no? So it attenuates the sound waves. Ibig sabihin pinapalakas niya, no? That's why it increase. Napaka-importante ng posterior attenuation. Bakit? Kasi ito, notorious ang mga residents nito na lesions in the breast, dahil hindi siya itim na itim, they call it as solid nodules. No, nagiging BIRADS 3 minsan or minsan 4 pa, no? Importante yung posterior attenuation. If you have a structure na hypo pero posteriorly tumataas yung echo or nagiging mas bright, that means you're looking at a cystic structure. Yun nga lang, meron siyang mga cellular debris. Kaya siya nagbumukhang hypo. Let's use this particular example na pinapakita mo ngayon, no? I'm sure that this is cystic. Bakit? Tignan mo yung likod na wall ng lesion. It's brighter, di ba?
Yes, for
Oh, may posterior enhancement kasi. May posterior attenuation. Yan, that part, no? Ituro mo yun sa right side ng lesion. Punta mo yung arrow sa right. It's dark. Nagiging black. So, solid yung dinadaanan niya. Habang dumadaan kasi sa solid na structure ang sound waves, unti-unting nawawala yung strength niya or power. No? Hindi katulad sa tubig. Pag dumaan siya sa tubig, di ba, parang ano yan eh, parang yung mga submarine at saka yung echolocation ng mga ang tawag dito, ng mga dolphins, pinapalakas niya yung sound waves. Ano nangyayari? Bumibilis yung transmission, lumalakas yung sound waves. Pagdating niya sa posterior wall ng ng lesion, energetic pa siya, dami pa niyang power. So, mas natatraverse pa niya yung posterior portion, no? So, technically, ganun concept. So, ano talaga, na importante yung physics sa mga radiologists. If you know the physics, how these images are produced, no? So, mas madali mong maintindihan. Okay? May tanong ako, last na lang, Christian. Have you encountered a lesion na 1 point lang? Ito, actually, hindi ko rin alam ang sagot nito eh. Have you encountered the lesion na 1 point lang?
Kasi sir, ang nakalagay po dun sa nabasa ko, kapag ano na siya,
2 points kasi agad eh. Ang BIRADS 1 mo, 0. Ang BIRADS 2 mo, 2 points. Wala bang 1 point? Kasi ang alam ko, halimbawa, if you have a cystic lesion, halimbawa yan, no? Use that example, no? Make cystic and solid. 1 point yan. Bakit hindi yan walang TR for that? Hindi ko nabasa. I'm just trying to analyze. Any idea? Ikaw,
feeling ko sir, kasi usually kapag may, kasi madadagdagan siya kagad ng another point pagdating sa ibang categories po kasi sir.
So like what? Let's use this example. Yan, that one.
Yes po sir.
Wala siyang echogenic foci, wala siyang extrathyroid extension, well-defined siya. It's complex, kaya 1 point. Oh, bakit wala siyang thyroids? For 1 point.
Pwede mo.
Oh, kaya ko sinasabi to kasi nag-ultrasound na kayo, no? So, baka score lang tayo ng score. Anyone who wants to guess? Yung mga nag-HB na, Butch, Tin, kayo, halimbawa, pakita kayo ng ganyan lesion. Bakit hindi 1 point ang thyroids niyan?
Yes. Yan, Doc?
Oh, ba't yan? Anong thyroids mo dyan, Butch? Ilang points pala? Wag thyroid, sorry. Ilang points ang bibigay mo dyan?
That's all. Pero yung iba pa yung nakastudent.
Kodigo natin, Butch.
So, hanapin namin.
Opo. Makakodigo kami, may kodigo kami.
Hindi na kailangan kodigo. Oh, ang sagot kasi dyan, guys.
Mas maraming cystic.
If you have a complex, a mixed cystic and solid. So 1 point ka eh, no? Tama
Yes,
ba?
Doc. Opo.
Hindi ko? Talaga, 1 point pala siya. Akala ko 0 siya.
1 point
Kasi
One
siya.
point siya, Doc. Kapag mayroong
One
ano,
point. Okay. Sige.
Kapag mix.
unless
Oh.
sobrang ka ng isang ano, ilang.
Hindi,
Pag pure cystic, 0.
0. Yeah, sorry. Oh. Balik mo muna doon, Christian. Oh. Kasi pag meron kang complex lesion, may mixed cystic and solid ka, you need to grade the split component. Kaya walang 1 point na TIRADS. Kasi technically ito 2 points to. Kasi complex ka 1 point, tapos yung solid component mo is isoechoic, which is ano ba yung isoechoic?
1.
1 po yung
point.
ISO ko.
1 point.
So technically 2
2
points
point
yung
po.
TIRADS.
TIRADS po.
Kaya walang 1 point na TIRADS. Di ba? Nakuha niyo kung ba't walang 1 point? Pagtapos ng 0, 2 siya agad. Kasi if you have a complex lesion, you need to grade the solid component also. Kung iso ba siya, hypo, no? Kung hypo siya, di another 2 points. So may TIRADS 3 na lesion ka. Tama? Okay. So, yun lang naman. Any questions kay Christian? Anong ginamit mong...
May question ako, Doc.
Oh, kay Christian.
Oo. Kailan
Sige, go.
ipa-follow up? Ilang
Yun.
years ipa-follow up yan?
Actually, yan yung itatanong ko eh, na naunahan lang ako ni...
Sorry, Doc.
Pero, hindi, ang itatanong ko muna sana kasi kay Christian, anong source mo? Kasi kung yung ACR ang source mo, meron silang guidelines for follow-up niyan. Kasi sinulat mo yung follow-up, di ba? Nakalagay doon. If the lesion is 1.0 na TR3, follow it up. No? Pero hindi nakasulat kung gaano katagal. How long is the follow-up? Or how short? When is the next follow-up? Wala. Nawala ba kayo? Nawala ako.
Dito pa po.
Yan, okay, sige. O, si Ursi ata alam eh. Ursi, anong sagot?
Doc, nilalagay ko lang follow-up 1, 2, 3, 5 years.
Oh, actually, ang follow-up 1 year. At least. Huwag kayo magpapa-follow up ng pasyente na after 6 months bumalik po kayo. Bumalik kayo. Walang use yun. No?
Opo.
Pa-mute na lang muna. Ano kasi, yung follow-up, ang basihan kasi niyan is doubling time. No? Just like for breast cancer, the doubling time in breast cancer is around 3 to 6 months. That's why yung Virals 3 natin, the follow-up of malignant breast cancer could be between 3 to 6 months. Kaya yun yung follow-up natin. So they found out ang doubling time ng lesion ng malignant lesion sa thyroid is 1 year. So wag kayong may relative kayo na TNR ganito nyo, suggest follow-up lang dahil hindi pa nag-ano cut-off. Ang follow-up is technically 1 year. No? Haba, no? Tsaka napakababa. Have you seen the risk of malignancy? Tama ba? I'm not sure if it's 20 or 35% lang for TIRADS 5 ata. It's quite... Hello? Narinig pa ba ako?
Yes po, sir.
Oh, so the chances of malignancy is quite low pa din talaga. No, so hindi ka basta-basta nagpa-follow up. Tama. Ako pala may question sa lahat. Actually, baka naririnig to ng Binyan people kasi may pinag-uusapan kami. How would you define a doubling time sa pulmonary nodule? Off topic to Ibig sabihin ba dapat doble? What's the magic number?
Hindi.
Ha?
Tama ba? Parang 25% yan.
Tin or C?
Or
Butch. Ibig sabihin ba, halimbawa, may 1.0 ako na lesion, tapos naging 1.3 siya. After ilang months, ibig sabihin, hindi yun significant growth or hindi yun nag-double. Hindi siya significant doubling time. Or hindi siya significant growth. Dapat ba doble?
Parang 25% man.
Ilan? Parang may narinig ako. Tamang sagot.
Sir, 25% po.
Oh, okay. No? Actually, ang alam ko nga 1.2 eh. No, pinag-usapan kasi namin ng mga binyan residents yun. No? So, it's not doble. No? So, if you have I use a number na how will I say that there's significant growth? If it's, nadagdagan siya ng 20% lang, you don't need a growth of 1 magiging 2 centimeters. No? I think parang ganun 25%, 25%, no? I'm not sure if it holds true to all lesions, but for pulmonary nodules, bigla ko lang naalala. Oh. Tama yung sinabi ni Doktora Ursi, 135. Ang weird, no? Ang haba, no? Pero ganun talaga eh. Kaya nga yung iba, nauwi talaga sa biopsy. Kasi instead of waiting for a year, kung kaya naman i-biopsy, we can do biopsy talaga.
Kinopya ko yun, Doc, sa report ng iba.
Ayun, no? So, pero, kasi madalas kasi, colloid nodule lang din talaga lumalabas eh. Pero last week, we have a TR3 nodule. Yun nga lang, matanda na lalaki. Ang lumabas, papillary, no? So again, ayun yung mga instances na, yun naman kasi malaki yun, kaya talagang Okay? Any questions for Dr. Cristiano? So actually, maganda yung reporting natin today, no? Ganun talaga. Medyo maganda head and neck. May question pala ako sa inyo, guys. Kailan sinet yung deadline ng submission nyo sa research? Sa interesting case. Kailan natin sinet? October
Teka.
October.
Sinet natin October something eh. Yung isasabit niya sa amin ni Doktora Moran para pagpilian namin kung sino magpe-present.
Parang 25 po, sir.
Oh, alam ko nga eh. So, dapat natatapos nyo na. Ito guys magiging strict ako dyan na kasi ayokong mangyari na ang gagawin nyo is medyo hilaw na research lang or interesting case kasi anyways isa lang naman yung pipiliin. Before kasi lahat yan sinasubmit sa taas, no? Tapos it's a requirement that everybody should be presenting, no? Ngayon kasi pipili lang yung department kung sino yung magiging representative, tama, no? So dandahan nyo ha. Kasi nakakaya sa ate Jack nyo champion last year. Hindi naman tayo magpe-place this year.
The question, meron ba tayo for research?
Oo. Sinubmit na sa akin nung dalawa. Pero syempre, ang may call, ang may final na say kung sinong magpe-present o hindi, si Dr. Bernaldez, no? She's the head kasi ng research, no? So, I'll let her decide kung sino. Pero definitely, it's either Manny or Cathy, no? Pero with regard sa interesting case, gandahan nyo submit kayo kasi nakakaya kay Dr. Jack. No, tsaka every year nagpe-place tayo. We don't want to break the streak naman, no? Sayang naman, no? Isa sa pinagmamayabang natin 'yan. And sinabi natin yan sa accrediting committee at tuwan-tuwa sila, no? So, something that we could still boost, no? When we have our re-accreditation 3 years from now. Okay, please ha. Gandaan nyo. Ano naman, when you submit it to us naman, pipili kami, then yung presentation, ayusin natin. I mean, gagawin natin ng paraan. Just like, di ba, yung kay Jack, di ba, Jack, isa pa natin, di ba? Kasi yung DSA na pinigay kay Jack, hindi namin initially maintindihan pa no? So, inanalyze pa namin ng gusto, no? So, para, maganda. So, please, give a good present, naman. Inisip ko
Yes,
pag-present kaya namin kayo. Tapos mamimili kami. Ganun na lang kaya, siguro. Kausapin ko Doktora Moran. Hindi, sorry ayoko lang kasi talaga na baka mamaya medyo mag-ethics lang eh. Pero hindi kasama si Nico dito ha. I think it's the 6 residents, no, from WALDS to the 4 WALDS pads and the 4 first years pa.
6 lang, Doc.
Anim. Kakausapin ko na lang si Doktora Moran. Si Doktora Bernades. I'll ask her, Doktora, gusto niyo ba paggawan na rin natin ng presentation to para at least medyo formal ng konti. Then we'll choose among the 3 of you. Siguro ang gawin na lang natin, video na lang. Sorry tinoksi ko kayo pero siguro, when you submit it, you just submit the transcript muna. Send nyo namin transcript, pagpipilian namin then siguro mamimili kami ng kung sino lang yung maggagawa. Then from there, pipili din kami. Gusto ko magbigay ng incentive kasi kung ikaw yung napili, di may something na dapat na mapunta sa'yo. Mabawasan ka ng duty or something. No? So para at least may gawin ka for the effort, may benefit ka or may you get something for it, no? Okay? Wala na questions?
Wala na po, Doc.
Sinong MR?
Ako po, Doc.
Sige stop share screen na Sige. Pwede na Manny, thank you Tsaka sa mga Binyan people, thank you.
Ay po, Doc. Thank you po.
Thank you, Doc.
Okay. So, ang matitira sa akin, sige, pwede naman yung mga fellows if you, para.
Hello, Doc.
Okay, share screen ako, Pads.
Hello?
Mag-share screen ako.
Hello, naririnig po ba ako?
Yeah, Pads.
Okay. Na po ba tayo, Doc, ng MR? Bali, Doc, may 4 na patients po kayo.